Welcome to the 2026 Best of Lung Cancer Special Edition podcast from the Society of Thoracic Surgeons, where we examine the science shaping the future of thoracic surgery. I'm your host, Dr. Erin Gillaspie, and today we're discussing the best science from the 2026 European Lung Cancer Conference, which brought together thoracic oncology specialists to discuss and share the latest advancements in lung cancer research and treatment. Joining me today is Dr. Jonathan Spicer, an associate professor of surgery at McGill University, and of course, a favorite on the Thinking Thoracic podcast. He attended and presented at the ELCC, and I'm so grateful that you're here today with me, bringing us all of the exciting updates from the meeting. Welcome.
Thanks, Erin, for having me. Always glad to join you on this podcast.
Thank you. So, oh my gosh, a lot of really exciting ground was covered at ELCC. There was obviously a strong focus on advanced stages of lung cancer, improving research, improving clinical practice. When you think about ELCC 26 as a whole, what stood out to you as some of the most exciting science data? What should thoracic surgeons really be paying attention to right now?
Yeah, so I think what was clear from the way the conference, how the topics were disposed and presented, is that we're in a bit of a transition period with regards to new data about the resectable space. You know, we've had like 3 or 4 years of just constant new major disclosures from phase 3 trials. There's a lot less of that now, but there's this emergence of surgically guided real world studies, in-house academic studies that are producing some really interesting results. So it's like there's a lot more academically led discovery happening that I think is exciting and interesting, but just unfortunately doesn't always get the same disposition or weight that it should be given, in my view anyways, but a lot of exciting, interesting things being looked at.
I love that. And it seemed like there was a lot of practical sessions too. So discussions on thymectomy, extent of resections for thymectomy, challenging some of the dogmas of operating even on stage 3. And so that is where I sort of wanted to dig into this conference, because one of the sessions that really caught my attention right away is defining the limits of surgery in lung cancer. And literally the session spanned everything from segmentectomy all the way to where surgeons belong in the stage 3 and stage 4 space.
Just a general comment about that. I think ELCC is a great conference for North American surgeons to consider, especially if you have an interest in lung cancer, thoracic malignancies. You know, European thoracic surgeons, that is almost all they do, unless they're also transplanting. And there's a really tightly knit and very rich community of surgeons, oncologists, radiation oncologists who all know each other quite well and, you know, are regularly at these meetings and other cooperative group efforts. And they really have very well formed thought about a lot of these problems. And the sessions are well organized around that. So there is great discussion. So I would say these sessions were cool. Thinking of the people speaking has evolved enormously. You know, a lot of the thought leaders in thoracic surgery might have presented much more dogmatic views 3 or 4 years ago about how we should approach surgery in this evolving space. And it's clear that the thinking is evolving with the new practices and adopting new ideas and thinking kind of creatively about how surgery, what the role of surgeons is and the role of performing surgery is evolving. So it was a great session. And you're right that, you know, we're entertaining a lot of things that we never would have considered before.
I love that. And actually, I love the shout out to all of the incredible oncologists and European surgeons who are also all of our friends and who have really done an extraordinary job running very robust clinical trials, presenting that data, and really helping to move the surgical field forward. I mean, some of the most compelling surgical trials in the last decade that immediately pop into my mind are things that have come out of Europe.
It's true. Yeah, they're well organized, and
Yeah.
they're able to get their ducks in a row and pull in the same direction, which is nice. Yeah.
I love it. Okay, so let's go through sort of the spectrum of surgeries. So take us through some of the conversations, especially about segmentectomy, because I don't know about you, but when I saw the 10-year updates from the JCOGO 802 trial and the sort of, I guess a lot of people are calling it bombshell statement from Asamura standing up and declaring segmentectomies dead and that we should all be doing lobectomies now, which was a sort of a big turnaround from all of the 5-year data. What are people talking about right now with regards to smaller tumors with regards to segmentectomy. Is segmentectomy dead in the water? Should we still be doing this? What was the sentiment of all the people in the room?
I think so. You have to start from the perspective that, again, this is a mostly European surgeon cohort who are generally traditionalists about the importance of lymphadenectomy and anatomic resection. So there are very few European surgeons who would say a wedge resection is an acceptable form of surgery for lung cancer, period. So
Yeah.
they're starting
Yeah.
from that dogma. And that's in spite of, Calgb, Al-Turki study and all that. So that means that the default for them, for those who might be swayed by a presentation given in Japan that's never been published or presented
Yeah.
by the PI, but who is also admittedly biased towards lobectomy, might be swayed to go back to lobectomy for a 8 millimeter tumor at the periphery. so,
Yeah.
so I think it was a bit overblown, honestly. I'm not talking about ELCC, but like just
Yeah.
from my perspective, the most educated, rational, and scientifically accurate interpretation of that presentation and
Yeah.
the discussion around it has been offered by Dr. Al-Turki
Yes.
in something I saw online. He is absolutely on the ball that the only thing we can conclude on is the primary endpoint
Yep.
and everything else is exploratory. The
Yep.
study wasn't powered for a 10-year overall survival
Nope.
outcome. The outcome that is statistically significant and true and undeniable is that overall survival was better in the segmentectomy group at 5 years, which is what
Yep.
the trial was designed to do. And everything after that is exploratory endpoints that are underpowered to in a space that is razor thin margins to show any differences
At
of
all.
any kind, right? So I think most people are still performing segmentectomies. I think, the real question is, will wedge resections take a bigger place? Not will lobectomies reclaim this space? Yeah, I don't think anyone really truly believes that. There may be specific scenarios where you might be concerned about local recurrence. And I think the other thing that people are underplaying is the fact that JCOG was performed in Japan, where
Yes.
half the patients are driver gene positive. Now,
Yeah.
I haven't seen any data from JCOG that confirms to me that those recurrences are of the originally resected primary.
Yep.
We know that EGFR mutant patients who are non-smokers are at high risk of second primaries, and they
Yep.
could be in the residual lobe. And I haven't seen it. And I have my own patients that we've rebiopsied who are on trials like ADORA 2. And we're
Yeah.
trying to figure out, is this a DFS event of progressive disease of the resected primary, or is it a new primary that has emerged? And
Yeah.
we see new EGF when we biopsy them and we NGS them, we see new primaries. That
Yeah.
doesn't mean it's a failure of the segment. That is unfortunate biology of that patient's condition. They're predisposed to this. So people are going crazy about this talk, and it
They
is
are.
not founded in any kind of science,
I agree. And
unfortunately.
I'm so glad to hear your comments because I am still very much team segmentectomy. And I think what we need to be having much more candid conversations about, and this is where it's a call to action for surgeons again, is we need to be thinking about biology, and biology should be helping us to choose our treatments, I think, in a much, much, much richer way. Okay, so let's switch to the opposite side of surgical resections. So we're obviously in the ninth edition of lung cancer staging. It's further subclassified our nodes. So now we've got N2A, we've got N2B, of course. And for the first time ever, we have N2 disease falling into stage 2. And now we've got our, resectability categories really bridging stage 2 all the way to stage 3B for N2 disease. And in the last year, we've had a number of publications trying to define resectability. And this has come from our surgical organizations, it's come from oncologic organizations, one of the European organizations. So Brendan Stiles took up the flag for surgeons, arguing resectability in this space. So talk to me. We're 2 decades now after the publication of the INT-0139 trial. Can we finally move past the dogma of single station, lobectomy only for N2 disease, safe resections with better outcomes for patients?
Yeah, so I think one thing that was cool, there was a session that was really focused on, surgery in the era of immunotherapy and
Yes.
this concept of the immunosurgeon coming into
Yes.
place. And I kind of like it because it was a group of people who, had I heard them speak, well, when I heard them speak a few years ago, would not have like been so flexible about how we adapt our practice. And they really have become very interested about the interplay between biology, available therapeutics, sequencing, timing of surgery, extent of surgery. All of these components are being discussed in a very forward-thinking way, which is exciting. Sort of a personal bias here, and one that is somewhat supported by data, is that stage no longer matters. Unfortunately, we're refining the anatomic staging of lung cancer, but it has no clinical consequence or significance, right? We have BMS 77T Nature Medicine paper that was just published, I think in January, showing that if you're stage 2 or you're stage 3, if you've had access to immunotherapy, there's no difference in your outcome.
Yep.
If you've had access to chemo alone, there are the classic stage segregations that we see on EFS and overall survival from the classic TNMs. But when you bring immunotherapy in place, that doesn't apply anymore. So that means that in the era of immunotherapy, in patients who are eligible for that treatment and fit and like have the right biology for it, stage is no longer a stratifying factor for survival. So it really shouldn't be entering into your decision tree as to whether or not you should consider a perioperative surgical option. What should be is, can you do the operation safely, get the patient through? And in my view, there might be some component of stage that dictates whether you can do a safe surgery, but it's not really the major driving component. There are many other factors that dictate and stratify patients to whether they will have a good or bad postoperative outcome. And those are the things we should be considering.
Yeah.
So I think that's certainly evolving, and that's kind of bringing the concept, should we assess resectability after best systemic therapy first? Is certainly the argument that Brendan Styles made in a debate on that issue for these, really truly borderline by disease extent settings. Now that's not necessarily being heard or received by everyone. I think a lot
Yeah.
of people, again, there's strong presence of clinical oncologists who are radon jointly trained physicians in Europe who can wholly treat one of these patients with their own toolbox and continue to believe, with good reason, for many situations, of the value of chemorads and consolidation immunotherapy. So I think this is an open space ripe for more investigation, for more trials. We'll see.
Yeah, I think it's really exciting. And I think, with a lot of the trials showing really excellent clearance of lymph nodes repeatedly, right? Like we've seen it across all of the, neoadjuvant and perioperative chemoimmunotherapy trials. And with the addition of some of the new drug therapies, some of the ADCs making their way into that neoadjuvant space, I agree there's a huge amount of appeal to really putting that best systemic treatment forward to see how's that patient doing, and then choosing the best local therapy to make sure that we're
Mm-hmm.
controlling any residual disease. And so being much more nimble in our treatment selection and maybe not making as firm of decisions up front. I'm a huge fan, I think you are as well, of the neoadjuvant treatment, not only for disease control, but it's also a great time to leverage for our patients, right? You can work on smoking cessation, prehabilitation, get these patients to a really fit spot. So when they're coming into surgery too, not only is their disease really well controlled, but you have a much fitter patient that can tolerate a resection really well.
I suspect this is intentional on your part, but it's a great segue to some of the other work that was presented at ELCC on things like, there was a really nice piece around the microbiome from the Aegean trial, showing
Yes.
that there are well, this is, consistent with what we knew of the metastatic setting. But to your point, when we have preoperative window and we have so many different factors we can act upon, of course, smoking cessation, exercise, we have data about the benefits of exercise in combination with systemic therapies, but are there nutritional or diet or microbiome directed therapies that we could implement here that would make immunotherapy more effective. I mean, it really creates a structured approach to care that allows us to introduce new elements that can make the oncologic delivery more effective and the surgery safer and more likely to be curative. So those were some really nice pieces of data. There's also some stuff in the EGFR space from the NeoAdora trial looking at the role of metabolic downstaging to assess depth of response. In that space, it's not as good as what we're seeing in the immunotherapy space, but clearly we need better markers of what is the depth of response. How does that pre-operative information influence our stance going into the OR? Can we consider de-escalated surgery? All of these different things are being looked at. And now with this new structured approach to the patient journey, there's a lot of cool things we can do that are much more amenable to scientific investigation and learning, I think.
I agree. It's a really cool way to use all of this really rich data that they have from clinical trials. And so I'm really glad that you mentioned about the PERSIST, because one of the things that I've noticed is that not everybody has heard of PERSIST yet. And I think it's really important for surgeons. We are not mispronouncing resist, okay? You guys, this is a completely different thing. And, it's what we are using for restaging. So PERSIST, or positron emission tomography response criteria in solid tumors. And they looked at that for the NeoAdora trial, which was really incredible, because I think that's one of the biggest challenges, right? You get these images after neoadjuvant treatment and a lot of patients still light up and you don't really know, should we be comparing the SUV? Do we compare size? What is the implications of these lymph nodes that are still lighting up? Is that a reflection of residual cancer progression? Is it an incredible immune response? So we see sort of a different pattern, whether it's a targeted therapy or immunotherapy. And it looks like, in the targeted therapy space, to your point, with osimertinib for the NeoAdora, that actually the PERSIST response is reflective of major pathologic response, a reduction in the median residual viable tumor, and is actually correlating with EFS, which is really exciting.
Yeah, but it is much more modest than what we've seen in the immunotherapy space. I'm just looking at the data now, but so patients who had a complete metabolic response had a median percent RVT of 20%. Those who had a partial metabolic response, it was 30%. Stable disease metabolically was 50%. Progressive metabolic disease, the median RVT was, in the same, actually 52.5%. So we're not seeing, because we don't have that cohort of PCR patients.
Yep.
Complete metabolic response is, yes, MPR, but how is that helpful, really? So it's not quite sensitive enough to help us really know if there's been a complete response yet. There may be new tools that we can, or refinements of these strategies that could be informative.
Absolutely. And it's tough. It's tough in these targeted agent spaces because, to your point, it's a very, very small group of people who are achieving path CR. I think it's, sub 10%, maybe 6% of patients who are actually achieving that path CR. So it's a small cohort of patients. Okay, I have to circle quickly back to the AGN because you mentioned something that I think is going to surprise a lot of people. And it is exactly that, microbiome characteristics. And so they looked at patients and the Bifidobacterium longum, which is, I guess, a normal gut flora that some people have. And if you have it, you're going to respond better to chemoimmunotherapy. Amazing. So now listen, I went into thoracic surgery to stay as far away from the colon as possible. Are you telling me now I'm going to have to start looking at the microbiome of my patients and their stool?
I think probably not. I don't think, how should I put it? I don't think we're going to be using this to select whether or not to give patients immunotherapy. I think this is informative about how, because there's a lot of science about microbiome is a very is a exploding field. There's a lot of science about how the presence of these good bacteria, microbes, are impacting the systemic immune response to cancer. And I think it's more about how do we cultivate those floral changes in gut of our patients to ensure that a greater proportion of them will respond. It is impressive. You looked at
Yeah.
ctDNA clearance in the presence or absence of these gut flora, and they like huge separation between those who cleared their ctDNA and those who didn't. But that was only true in the durvalumab arm. So it is really something that is specific to the receipt of immunotherapy. Two of the scientists I work with here at McGill just published in Nature a huge study, now granted in mice, but looking at a dozen or more different diets, all the things that we think are good for us, the
Yeah.
Mediterranean diet, all these different fad diets have been looked at, and with models of immunotherapy responsive, non-responsive cancers. And there
Yeah.
were some extremely surprising findings about that. There's like a lot of cool stuff, and it is related to the microbiome. There's specific lipids, fatty acids that facilitate the growth of good gut flora that then lead to better immunotherapeutic responses. So, stay tuned, because there will be, without a doubt, neoadjuvant trials looking at the implementation of these types of nutritional modifications.
That's amazing. So really, really just exciting things coming out of all of, again, expanding on all of the knowledge that we have with these trials. One more surgical topic to dive into, and that's our Keynote 671 updates. And so they came in really interestingly to this conference, and they gave two presentations about updates, and they broke them down by path CR versus non-path CR. This is our surrogate marker that we're talking about a huge amount now, which really does portend very, very different outcomes for our patients, as we look at the long term. So give us the highlights. What did the researchers share about the updates for their non-path CR arm and their path CR arms in the Keynote 671?
Yeah, so at this point, these aren't, groundbreaking. We kind of know what these outcomes are. They've been looked at before, but it's the first time for 671 that the EFS curves at 5 years have been shown by depth of pathological response. So we have patients with PCR had much better event-free survival than without. So this is to be expected. It's 81% EFS free patients at 60 months versus 43% if there's a non-path CR. So this has been the foundation for all the escalation trials after induction therapy, and makes sense to me. So those eventually will complete, and we will see the results. But whether or not you are in PCR or in non-PCR, the pembro treated arm continued to perform better than the placebo arm. Doesn't really help us know which component pre or post-operative is the driving factor, but the hazard ratios are all very strong in this trial. Now, perhaps the most interesting part of this was Mariano Provencio's discussion of he really has a high level intellect and view and understanding of this space. He points out there's some really nice plots of the individual patient trajectories. And he points out that there are a number of deaths without progressive disease in the PCR patients. Problematic, and we don't exactly know why, but that's not due to lung cancer. So these count as EFS events. So if your justification to saying we should give perioperative because EFS isn't 100% in PCR patients, say, well, wait a second. Some people die not because of lung cancer. And so that's not to say that they die from prolonged exposure to immunotherapy, but doesn't entirely exclude that possibility either.
Yeah.
And then the other thing he commented on, which I thought was interesting, is the interpretation of EFS. And I've seen this in my own patients who've been on various trials, is that it's not that uncommon for the blinded review of the CT findings at any point out from the surgery to call an EFS event. But
Yeah.
you have not changed your treatment of the patient. You're looking at them and you're like, you don't have cancer. I don't know
Yeah.
what this thing is, but it's not
Yeah.
making you sick. Or we biopsy and it's a granuloma, but the patient is now post-event. So that data is no longer being collected in the trial, and we don't necessarily know. Which is why in 816, you have 95% overall survival and no deaths from lung cancer, but the
Yeah.
EFS is lower, right?
Yeah.
Because some of those patients had radiographically blinded review called EFS event, but they don't have lung cancer. When Mariano looked at these in the different trials, Nadim 2, Checkmate 16, 770, Keynote 671, NeoTorch, and the number of patients with called disease progression in Keynote 671 was quite a bit higher. There were 14, whereas in the other trials, it was 3, 5, 4, 2. Now, granted, Keynote
Yeah,
671 is a much bigger trial, so
it
to
is
just put
double the number of patients, right? Yeah,
double,
compared to 816. Yeah.
but if you look proportionally,
Mm.
percent of patients with disease progression is more than double what it was, for example, in Checkmate 770 or Checkmate
Yeah.
816. So is there a bit of an overcall of this EFS event? That's why we need the OS data
Yeah.
from 5 years in these by depth of pathological response.
It's incredible. But even if it's overcalled, an 81% EFS rate for stage 2, stage 3 patients, a huge number of whom had N2 disease. I mean, 10 years ago, we never would have been talking about numbers like this. It's really, really extraordinary. So just really exciting future for treatment in our patients. And then, for the slightly lesser EFS for the patients with the incomplete path CR, I agree. I'm very, very excited about the escalation trials. And that's something that we're all talking about, we're all buzzing about, sort of the future of clinical trials, both currently that are in progress and future, not only to help better define the contribution of components, so which part of the treatment is really achieving the outcome that we're endeavoring to accomplish, but for patients who are not getting that path CR, how we choose the treatment after surgery to make sure that we can keep that disease controlled really, really well so it doesn't come back.
Mm-hmm. Absolutely. No, I think those trials will have some interesting results for us.
Agreed. Amazing. Thank you for all of this incredible discussion. Very, very exciting things that came out of ELCC.
Yeah, the one thing maybe I'll add, there's a lot of cool stuff that different groups are looking at is maybe disruptive, okay? But this was, I think, a study out of Taiwan. No,
Okay.
it was out of China. The title is aumolertinib, or AI predicted EGFR mutated pulmonary ground glass nodules, a single arm phase 2 trial.
Okay. Okay.
So aumolertinib is like osimertinib or lazertinib. It's a later generation EGFR TKI.
Okay.
And so they show about 25 or so patients that had part solid lesions on CT, and they applied their AI algorithm, which helps them determine a high probability that the patients are carrying an EGFR mutation and that it's cancer. No, this is not biopsy proven.
Yeah.
There's no biopsy done, just a CT. So I get some clinical information and AI algorithm providing the likelihood of EGFR mutation
Yeah.
from that information.
Yeah.
Patients were then treated with aumolertinib, and there is something like 80% partial response rate. There were 4 patients who were in complete response, no surgery.
Interesting.
Now, if you think about it, our trigger, I think in North America, Europe often is an 8 millimeter solid component.
Yep.
What if you see this patient, you apply the algorithm? Oh, this is like 95% EGFR disease.
Yeah.
We don't expose the patient to risk of biopsy. You
Yep.
give them 3 months of your EGFR TKI. Maybe that solid component disappears. We know the risk of metastasis if there's no solid component greater than 8 millimeters is extremely low.
0. Yeah. Yeah.
Maybe you just watch that, see if that solid component reemerges. I
Yeah.
mean, it completely I mean, it's a small phase 2 trial. Who knows what it shows? But
Yeah.
it raises the possibility that we could treat early lung cancer like this
Yeah.
in the specific settings like pneumonia. And
Yeah.
it is the reason why I advocate that thoracic surgeons whose practice is primarily based in lung cancer care to consider learning to prescribe these medications,
Yeah.
because it could be a very real part of our future, and what a nice, you have an 83-year-old patient with one of these things who's
Yeah.
got not great lung function. You don't want to SBRT this patient necessarily. You don't want to put them through a ion guided biopsy and all this stuff. Like
Yeah. Collapse their
maybe
lungs, peripheral lesion. Yeah.
I mean, like I
Yeah.
think, but you still want to be able to look after them,
Yeah.
possibly. So I I think this is something we need to pay very close attention to.
Agreed. That's super, super, super exciting. Very, very interesting. And it just kind of speaks to the ongoing evolution of how much lung cancer therapy is going to continue to change based on the biology of tumors, right? That seems to be one of the big take-home messages from so many of these conferences these days. If you had to
Absolutely. Yeah.
summarize your top three things, top two things from this conference that you want everybody to remember, what would they be?
Oh, well, this is what I told people at the surgical takeaway session. I think now is the time for academic exploration in this perioperative world. Um, we have and surgeons ought to play a leading role in that.
Yeah.
So set up your programs in such a way that you can gather data, that you can learn things. There's so many cool, interesting, innovative ideas that you can investigate, and so it's kind of our time to contribute. Um, I think EGFR mutant early stage disease is really on the verge of a transformative change. You know, we're going to see data from ADORA 2. There are other earlier phase TKI, adjuvant TKI trials for high risk EGFR mutated disease. So that space is going to change, I'm sure, soon. So we have to think creatively about that and how we continue to be relevant. Um, Pathological response is still the dominant prognosticator in the neoadjuvant setting. So how does our TNM staging evolve, both clinical and pathological in the future? And how do we stratify patients to different treatments if TNM is not as informative as we thought it might be? And really, we're in an era of an explosion of biomarker discovery. So it's going to be increasingly personalized efforts, but a lot of interventions that we can bring that are biomarker directed that are within kind of, I think, the purview of surgeons in the perioperative period that we could improve upon. So those are kind of like the main themes I think are coming through.
I love it. Sounds like an absolutely extraordinary conference. Big plug to encourage all of our surgery friends. Please attend these conferences. The oncologists are incredibly welcoming. They love to share their passion for lung cancer. They love to hear perspectives from the surgeons. They love to partner, collaborate, coordinate. They want us as part of these trials. So please make an effort to go to all of these.
Thanks so much, Erin. It was fun.
You guys, there was a couple other interesting, slightly less surgical updates that I wanted to share as well. So last year, one of the really hot topics that we talked about was sort of this show-stopping paper that was presented at ASCO that suggested that the time of day may actually impact the efficacy of immunotherapy. And by golly, it took social media, patient advocacy groups by storm. Now, less than a year later, we have another paper coming out saying, hey guys, hold your horses. This may not actually be the case. So at ELCC this year, Solange Peters gave a paper in actually one of the proffered patient paper sessions. And what they did is they did a study called Propensity Matched ETOP Roche I-Time Study. And what they did is they took 8 different trials, international randomized controlled trials in which patients with lung cancer received immunotherapy alone or in combination. They defined morning versus afternoon based on noon, so 12 p.m. noon time. And they said, all right, did these patients get these drugs before noon? Did they get them afternoon? And how did they do? And the researchers from this found no difference for patients who received their first 2 infusions, those patients who had a minimum of 2 infusions in the morning versus afternoon. So it made no difference in overall survival for these patients. Now, the other very interesting thing to mention is that the lung time trials, that was the one that was presented at ASCO last year. This was actually published in Nature Medicine. It is now accompanied by a note that was added by the editors suggesting that there needs to be some additional review of that paper. There's some inconsistencies in the protocol and some questions regarding the study's findings. So stay tuned. We do not know where this is going to land, but for right now, we do not know of a major impact on patients based on this new data with the time that they're receiving their immunotherapy. So please reassure all of your patients, immunotherapy can be given any time of day. Don't be fighting for those seats in the infusion centers. Just get the treatment that they need to give us the best systemic therapy for our patients. I think it's also really important to talk a little bit about KRAS. So the ELCC meeting was just jam-packed with sessions, presentations, hot off the presses results, a lot of these earlier phase trials, but looking at KRAS. Now, what is KRAS? So KRAS actually was one of the very, very first mutations found for non-small cell lung cancers. It occurs in about 25% of lung cancers. It's one of the most common non-small cell, especially really common in the United States, and it acts as a driver mutation for uncontrolled cell growth. And it was for a very long time considered undruggable. So discovered in 1982, really fast forward, 30, 40 years before we have a lot of drug therapies for it. We do have approved agents that includes things like sotorasib, adagrasib. Those are available for KRAS G12C mutations in the locally advanced and advanced settings, but we see these drugs trickling down now into earlier stage settings. One of the major presentations here was actually for a new drug specifically targeting KRAS G12D. The really nice thing about this phase 1 trial showed that this new drug, adagrasib, actually has a safe side effect profile, a 35% response rate for patients who've already received one line of therapy. So these are our locally advanced stage diseases, and actually a pretty reasonable duration of response in really the early review of this trial. So some really positives here. One of the main reasons that I'm bringing this to our surgical colleagues to hear about is there are ongoing KRAS trials in the earlier stage space. And unfortunately, we've had some challenges with them. So we've already seen trials that have come to the forefront for both sotorasib and adagrasib, and they closed because of accrual challenges. These were neoadjuvant trials. There are ongoing trials, including a trial by Lilly. They're using olomorasib post-resection, so an adjuvant KRAS G12C trial that is actively recruiting. It's phase 3. There's Nautica-1, which is an incredible trial that is sort of a basket trial, so a lot of different mutations. They're using different drugs to target all of those, including divarasib for KRAS. Unfortunately, some of the arms of that trial have closed as well due to accrual issues. So this is a call to action to all of our surgical colleagues. Please, please, please keep your eyes on these KRAS trials. Make sure you're opening them at your institutions. Talk to your oncologist. Let's make sure that we're getting patients on these trials. These drugs are being especially incorporated in escalation trials. And so that's one of the things you heard Dr. Spicer and I talk about. There are a lot of escalation trials happening. How are those working? Well, we're giving our standard neoadjuvant chemoimmunotherapy, taking these patients to surgery, taking out their tumors, looking at them under the microscope. For those patients who do not have the response that we're looking for, they don't have a PCR, they don't have an MPR, we are thinking about additional drugs in that adjuvant setting. So not just going back to that same immunotherapy that they received before surgery, we're thinking about adding additional drugs to really try and drive up that event-free survival and overall survival for patients. So a lot of really exciting things happening based on that pathologic complete response. So really just an extraordinary time to be in the field of lung cancer. Last year, I think we had more approvals than any cancer type for new drug therapies for our patients. So congrats to all of our incredible oncology colleagues, all of our surgical colleagues for all the incredible work that's taking place in the field of lung cancer. We're so grateful for all of the extraordinary ways that this is impacting patients. For our listeners, you can find more information and related resources at sts.org and in the show notes. Until next time, I'm Dr. Erin Gillaspie, podcast host at the Society of Thoracic Surgeons. Please follow the 2026 Best of Lung Cancer Science Special Edition series, now available on all popular listening platforms, including Apple, Spotify, iHeart. Please don't forget to follow me on Thinking Thoracic, an STS podcast that offers candid conversations about the latest advancements and challenges in thoracic surgery. The podcast is also available on all of your favorite listening platforms. Keep taking great care of patients, and as always, keep smiling.